Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear viewers, ladies and gentlemen. Happy and blessed Ramadan, and may Allah accept your fasting and good deeds. Dr. Mohammed Alsheef, your host of Elixir of Life, kicking off another inspiring and informative episode with our distinguished guest, aiming to explore new frontiers and bring you most up-to-date information related to health. Our program is filled with many inventive segments. Most importantly, our topic of the week is very juicy, very important: effect of fasting on diabetic patient. Without further ado, stay for a special episode. Stay with us. Once again, welcome back to our program Elixir of Life. Now we are coming to our episode theme. We'll be talking about diabetes mellitus and fasting Ramadan, or the effect of fasting on diabetic patient during the holy month of Ramadan. This is a very important topic, and we have quite interesting agenda. We know that the effect could be from multiple aspects, from dietary habit, from sedentary lifestyle, and who should fast Ramadan, who should not fast, what are the adjustments in diabetic medication. All these important questions, it will be answered by our distinguished and esteemed guest, Dr. Abdulraof AlMahfouz. He is consultant endocrinologist and diabetologist, head section of endocrinology at King Faisal Specialist Hospital and Research Center, and he is a chairperson of Endocrine Fellowship Scientific Program, and he is one of the giants in the field of diabetology, and he is highly published in the field of diabetes. Without further ado, welcome with me Dr. Abdulraof Mahfouz.
Thank you, Mohammed, for having me, and blessed Ramadan to you, the team, and the TV and the audience.
Yes, I'm sure you will enrich this episode with your vast knowledge and experience in diabetes.
Thank you. I hope I will live up to your expectation, Mohammed.
Hopefully. We'll start by a very traditional question. What's diabetes mellitus in a nutshell?
Okay, so in a nutshell, diabetes mellitus is a state where the blood glucose goes above normal. There are other abnormalities we will not get into, but that state occurs gradually in patients, and there are quite a number of types, but most people probably are familiar with type 1 and type 2. So most people are type 2, 90%, less than 10% type 1, and there are other ones that due to medication. This increase in blood glucose in the blood results from a number of defects or abnormalities in the way the body handles glucose. So as we know that glucose usually results from our food that we take, principally carbohydrates such as rice, fruit, and so on. And usually it is pushed into the cells of the body so that they can use it for their energy and for their synthesis. And that occurs usually through the hormone insulin, which is secreted by the pancreas. In general, type 2 diabetes, which is the most common, has a number of problems in handling glucose. There are two essential ones. One is the fact that the amount of insulin secreted by the pancreas goes low with time. So by the time a patient has diabetes, something like half of his insulin function is gone, although they don't feel anything at that stage. This is one of the defects. The other defect is the body is unable to respond to appropriate amount of insulin. We call this in medicine insulin resistance. So the body is resistant to the action of insulin. And usually that results from obesity. However, all of these defects usually comes from genetic predisposition. So people are born with some genes that predispose them to diabetes. The other reason is our lifestyle nowadays. Just like me and you sitting in this chair for this program, most of us actually sit in chairs in our work. And of course, there is plenty of food around, and so we eat, we do very little, and as a result, we put on weight that exacerbate the constitution of insulin resistance, and as a result, our blood glucose goes up in the blood. Once it goes above a certain amount, glucose is spilled in the urine. The kidney is unable to handle excessive amount of glucose, and so the patient may come later on with symptoms of increased urination, increased thirst, because the patient loses considerable amount of fluids and electrolytes. So that's basically in a nutshell what diabetes is.
Very beautiful. You mean the resistance of the peripheral tissues? What are the tissues that are, let's say, resistant to, effect of insulin?
Okay. So the two most important tissues that actually take up most of the glucose in the blood are the muscles that we use for work, for walking, exercise, and the fat. And also the liver also takes a lot of glucose that is stored, so that when we are fasting, we can go back to the body can go back to the liver and change that stored glucose so that the other cells in the body uses it. And some of those cells do not need insulin, such as the brain and the red blood cells do not need the insulin for the glucose to go there. And they rely in the fasting state, such as in Ramadan, on those stored glucose in the liver and other compounds that are converted into glucose from the muscle, so that when we fast, we can fast for days actually, and the blood sugar can be fine because of the physiology that we have in our body to go back to those stores and convert them into glucose.
Very beautiful, Dr. Abdulraof. Before we go deep, and I think very important and relevant to our discussion today, what are the types of diabetes mellitus?
Yeah. So as I mentioned earlier, most type 2 represent the most common types. Something like 90% of patients with diabetes have type 2.
This is adult type.
Adult type. Then we call type 1, which is usually occurs in childhood. However, nowadays we know more than what we knew before. Actually, something like more than 40% occur in adulthood in type 1, and it behaves almost like type 2. However, those people normally, they will need insulin very soon after their diagnosis. So the border is actually blurred now between type 1 and type 2. In fact, under the age of 20, a third of those patients have type 2 because of the obesity in the young. So now there is a sort of a blurred border between the two. However, for the most part, type 1 occurs in thin, younger patients, very, very young. It could be 5 or 6 years, while type 2 generally occurs in older, 30, 40, 50 years of age and so on.
And there are other types, rare types of...
Yeah. There are other types, which are so many of them, but they do not represent the majority. One is something that we produce as physicians by giving medication for other conditions. For example, rheumatological diseases, such as transplantation to prevent rejection. We give steroids, cortisone. That produces diabetes.
Steroid-induced diabetes.
Steroid-induced diabetes. There are other things, such as disease of the pancreas, such as inflammation, we call pancreatitis, can also lead to, and there are certain conditions due to excess of some of the hormones, such as what we call acromegaly, which is excessive growth hormone, or excessive cortisol, we call it Cushing, or excessive adrenaline, we call it pheochromocytoma. These can also produce diabetes, which is usually revert to normal once you control those conditions. There are other ones, but I don't think we should go into. They are rare and not very important.
Now we are coming to most important question, what you are waiting for. What's the effect of fasting Ramadan on diabetic control or diabetes control?
Yeah. So I think it really depends on what society you study, okay? So if you study societies where they do not have cars, they work all day long, the effect of fasting on diabetes are probably positive. Mm-hmm. Because people will eat less in general. Mm-hmm. However, I believe in our society, and there aren't many studies to that effect. I believe in our society the effect of Ramadan is in the opposite direction, where most people feast actually at night, and a lot of people probably eat more than when they are not fasting. As a result, diabetes control deteriorates. So the blood sugar will be higher, because not only the amount of food, but the quality of food that we eat. As you know, when you have that table full of all sort of type of food, they're all sweet, they're all oily, they're all lovely and delicious, but that plays havoc with our diabetes. The other aspect of fast and diabetes is the fact that we do less exercise. Most of the time we'll go to work for a shorter hour, so we're not going to walk a lot. We will be sleeping interruptedly, during the day and at night. We'll be visiting a lot of people, and usually when we visit people, we're going to be sitting around, not walking around. And the other effect as well, some people may adjust their medication downwards. That also will lead to increased blood sugar. Yeah. So all in all, I would say the effect of fasting on diabetes in our culture is probably in the wrong direction. Negatively. That's right.
But as a matter of fact, the philosophy of fasting should be a positive, impact. Okay?
Absolutely. I mean, when I grew up, and I know that I'm a bit older than you are, people work from 6 o'clock in the morning till about 4 o'clock, and they work hard labors. Active. This is about 40, 50 years ago. Now, most people, work very little, and they sleep a lot and eat a lot. So in the past, the effect were very positive. Now, I believe the effect, and this is, of course, related to lifestyle choices.
Yes. So the fasting, whether Ramadan or, outside the, Ramadan month, is one of the treatment modalities for diabetes. Okay, because diet is important component of diabetes. Is there any, that like effect on pre-diabetes or?
Yeah. So basically, when patients ask me, about diabetes treatment, I said the most important treatment now, later, and in the future is your lifestyle modification, your diet and your exercise. There is nothing better than controlling diabetes with controlling what you eat and what you do. In fact, if you look at people who lose weight, you can almost put diabetes into remission. People who are obese and do bariatric surgery, for example, diabetes remission is about 90% in 2 years. These patients are the one who loses 30, 40 kg of their weight.
90% cured?
90% in 2 years, they are in remission without any medication. So we're talking about morbidly obese. We're not talking about mildly obese. Sure. And so that tells you the importance of losing weight in the treatment of diabetes. It doesn't matter how you lose weight. In fact, we prefer the natural way, which is the diet and exercise, rather than the medication or surgery. But as long as you lose weight, you actually keep yourself away from all the medications that are needed to treat. Of course, sometimes you can't, and sometimes weight loss is not enough because you've lost so much of your beta cell or pancreatic function.
You touch upon very important topic. That's very important. The effect of weight loss on treatment of diabetes mellitus type 2, particularly morbidly obese patient, and the magical effect of bariatric surgery and curing or reversing diabetes mellitus. So I came across studies that fasting Ramadan and fasting without feasting, you lose weight. You lose 3 to 5 kg. This is, I will say, the intuitive, But here, as you stated, that we are finishing Ramadan with gaining 4 to 5 kg.
Yeah. So certain people do gain weight, certain people don't. These are the lucky ones, but I think the majority probably, finish Ramadan on a negative aspect. Just, I want to go back to this 3-4 kg. People who are like 90 kg, they say, what is a 3 or 4 kg loss? They don't realize that there is a major study for prevention of diabetes where patient lost only 7%. 7%, we're talking about 4 or 5 kg. That resulted into 60% prevention of diabetes. That's prevention of those people who are predisposed to develop diabetes. They prevent 60% of them develop diabetes by just losing 4 to 5 kg and about 120 minutes of exercise a week. It's nothing. But the effect is impressive, better than most medication that we have.
That's very great. Okay, so now the effect of the lifestyle changes on diabetes control. You already pointed out to the meal or dietary, changes. Can you elaborate more on our, dietary, habits or wrong dietary habits and effect? What are the really, major food?
So there are, we're talking about Ramadan here.
Sure.
In general, our body defends itself to hunger. So when we feel hungry, we defend ourselves by eating. And the more hungry we are, the more we want to eat. In non-fasting, it would be better not to fast for too long and then feel very hungry and go and eat as much as you can. But in Ramadan, you can't. And the best way to do it, actually, and I've seen farmers in the past doing it in Ramadan, which is take a small amount during breakfast, then go pray, do something else, and then come back in an hour or two and have a meal. That way, it gives you a sense of satiety with that small amount that you eat, rather than jump into all of that 20 type of food and suddenly you're just too hungry to think about it. Your stomach doesn't register that you are full until you're physically, and the food reaches almost like the top of the stomach. So it's better to eat a little amount. It's better to eat a low calorie amount to start with. I mean something like vegetables, something like salad, something like not refined food like white bread, no, brown bread, and so on. Something more fiber in it, more bulk, so that you can feel full without taking that much calories.
So the food, type of food, just salad and brown bread.
Soup as well, soup, something that is soup, it's very nice, it fills you up, water, it gives you that a little bit of fullness, and then you don't feel like you need to eat all of those greasy, sweet food that we have in Ramadan.
And the dates, what about the dates? Okay.
Yeah, again, the date, it's everything in moderate amount is allowed for the patient.
Sure.
So how much date we say? We say 3 dates is sufficient. The problem with dates is that it doesn't matter how much you eat, you don't feel full. You can eat 50 dates and you still can eat more. The 3 dates I talk about is equivalent to an apple. People don't realize it. 1 apple equivalent to 3 dates. So can you imagine if you eat 9 dates, it's like eating 3 apples. So that's a problem with it, and it's very concentrated, the dates. And you can never, if you're hungry, you can never have enough of it. So I would say take 3 dates and then move on to something else. Just put the 3 amount in front of you. Don't put the whole plate. If you put the whole plate, you'll never stop. That's the way. When you're hungry, you're going to eat more.
And you have pointed out to excellent strategy that you don't, feast immediately. It's like it has to be gradual. Okay, you start before prayer. Okay, you take 3 dates. Okay, and water. Then you go to pray. Then you come back to. So you prepare the stomach. Okay, not immediately. I think this is very important. We don't do it maybe nowadays. We immediately, attack. I will say attack the breakfast. Regarding the breakfast versus so for diabetic patient, they are allowed to take 2 meals like non-diabetic patient, breakfast and suhoor, or they should take snacks, and what modification, for suhoor, which one should be that, let's say, more they capitalize on the breakfast or the suhoor? Okay.
I would say everything is in moderation. I would say I think it will be very naive for us to say eat less in breakfast. I think they will eat more, definitely. So I think that will be the biggest meal. I think the sahur is not going to be a big meal at all, and it's better not to, because people will go to sleep immediately. So it's better not to overdo it. However, they should really follow a moderate diet. What is moderate diet? I think all of us, when we finish the meal, we are full. That means we overate already.
Okay.
So I think we should really leave the meal with some space left in our stomach. That means that we didn't overeat. So I think we should do it, and it should be a good mix of food, not just one type of food. Carbohydrates, or what. It should be vegetable. Should be a little bit of protein.
Is there any percentages? Or?
No, I don't think the percentages really matters as much. Although there are percentages, but most people don't look at percentage. How much of this. In general, they say 60% carbohydrate, but people, are going to eat what they say. But really, the thing that gives you satiety, that doesn't make you feel hungry, is actually protein and fat. If you eat protein and fat, you don't feel hungry. For example, if I bring you meat in front of you, you can only eat a small amount. And then you say, I'm too full, although you only ate a small amount. But if I bring you rice or bread, you'll eat, and eat until you're actually full. So carbohydrate doesn't give you satiety. It's protein and fat that give you satiety.
Okay, that's very beautiful. Should they take snack, between,
Okay, so in general, snack is only necessary if you're taking some medication and, that produces hypoglycemia. And again, there are some that may need or may not need. I think it needs specific patients' needs. So not all of them need, some of them need. And I think most of us, when we have good breakfast, we probably don't need much snack for a long time. We're too full to need it. But those patients who are, let's say, on insulin or sulfonylurea that produce hypoglycemia, they may need a small snack in between.
Excellent. Keeping in mind, we are fasting for 15 hours, up to 16 hours this year. Okay, so we have the period between the breakfast and suhoor is short. So that might not require a snack, as you pointed. What about the exercise? I know exercise is essential component of management of diabetes mellitus. What about exercise in Ramadan for diabetic patient? Before breakfast, after breakfast? This is a controversial issue that would like you to enlighten us about.
I think it will be very tough to ask somebody who fasts 15 hours to go and exercise. It really is, I would say, not done, even if you advise it. So I think most people will exercise during the night. Although in the past people worked physically non-stop, and I've seen them work on farms, during the heat of the sun, and they were fasting. Yes, it would be lovely, if they can exercise during the day. But I think, realistically speaking, I think most people would do it at night. It is known that if you do a little bit walk after meal, your sugars actually goes down. And patients come to me and say, Doctor, when my blood sugar is high after meal, I just go for a walk an hour or an hour and a half, come back, the blood sugar is better. And they say, good for you. That's exactly what has been found. Excellent. So a little bit of exercise, not like vigorous after a meal, it does reduce the blood sugar, the postprandial.
So what's the time after breakfast?
In general, about an hour or two, you can do that. Okay. As long as we're not talking about playing football, or we're talking about moderate physical activity.
Brisk walking.
Brisk walking.
Yeah, because that's I think really important, because one of the wrong habit that we immediately after breakfast we fall asleep. So what's the effect? Do you recommend this or?
No, of course. It's sometimes very tough to defeat physiology, and your physiology is important, because a lot of your blood goes to your stomach for the digestion of food, and suddenly you feel tired. But this is the time when you really don't want to do that. Try to fight it off and see if you can do a little bit of And again, it comes to how much you eat. When you eat a lot, you will feel that. When you eat less, you don't feel that.
So what are the risks, for diabetic patient fasting Ramadan?
Okay, so diabetic patients who are on medication for their diabetes face many risks. The most important is what we call hypoglycemia. low blood sugar, especially when they are taking medications that cause hypoglycemia. And there are some medications such as what we call sulfonylureas. We can quote I think most people are probably familiar with the brand name, things like Donel or Amaryl or Dimacron, all of these things. Or if they use insulin. So patients are at higher risk of hypoglycemia because of the fact that they're fast for so long. These medications don't know if you're fasting or not. So they're going to tell the pancreas to secrete more insulin and then bring the blood sugar down. This is one of the major risks they face. The other risk they face is hyperglycemia, high blood sugar. That result either from the fact that the patients overeat and they eat the wrong food, or reduction of their diabetic medication in order to avoid hypoglycemia. These are the two major risks. However, there is another risk, especially in type 1. Type 1 is really problematic when it comes to fasting. Remember, type 1 depend on their life to use insulin. If they stop insulin, they develop a state of what we call diabetic ketoacidosis, accumulation of acids in the blood and high blood sugar. They can get into coma. So if they cut down their medication dramatically by, let's say, 30 or 40%, then they are at risk of developing diabetic ketoacidosis. The patients from type 2 also at risk of developing what we call hyperosmolar state, where the blood sugar go very high, they go into coma. Again, this results from the fact that they reduce their medication, they eat too much, and from dehydration. Remember, it's hot and they're working, they're going to be dehydrated. They may even develop clot as well. So there are some major risks that the patients can face during fasting in Ramadan. And that's why it's important to recognize which one should fast and which one should not.
Dr. Abdulraof, you mentioned that hypoglycemia, if they develop or at high risk of hypoglycemia, how the patient do recognize they have hypoglycemia?
So most people have what we call warning signs. We call it in medicine adrenergic symptoms. That's the adrenaline rush. So what do they feel when their blood sugar goes down? They feel hungry, they feel their pulse going fast, they feel shaky, they feel sweaty. All of this as a result of the adrenaline that is secreted by the body to tell you there's something not right, go and eat. So people recognize it and they go and eat. However, there are some people who after many years of diabetes, especially type 1, like 10, 15, 20 years, lose this warning sign. And they go straight into what we call neuroglycopenic symptoms. These are symptoms that are characterized by confusion, dizziness, inability to concentrate, or even straight into coma. These are very dangerous situations, and those patients should not fast because they do not have the warning sign, what I call the bell that rings that tell them there's something not right, go and correct it. But most people have these symptoms and therefore they're able to correct it.
Hypoglycemia and awareness.
That's right. Yeah.
So you already, a patient is a diabetic patient who is fasting and experience, as you mentioned, hypoglycemic symptoms, and they check the blood sugar. What's the cutoff that they should break their fasting? Okay,
so in general, we tell them if you have symptoms and your blood sugar in the lower side, 70, 80, you should fast. You should break your fast.
70 to 80, yes.
Yeah. However, if they just happen to check and it's 70, 80 and it's not too far from breakfast, they can probably continue. They should probably check again. But if it's 70, 80 at noon, very likely they're not going to be able to make it. And so what I tell them, if they are not symptomatic, they should check again in an hour or so. If they're still low or going down, they should say, call it a day, break their fast, and adjust whatever they're taking for the following day.
Excellent. Do you have any percentages of diabetic patient who experience hypoglycemia, type 1, type 2?
So it really depends on what medication they are taking. So patients who are on diet, for example, patients who are on medication that do not produce hypoglycemia, generally they don't experience severe hypoglycemia. I mean, we can cause things like glucophage or metformin. Many people, at least in the community, call it, what they call it, I can't remember the name for it, but they call it different name. But it's glucophage oral. This does not cause hypoglycemia. The group called DPP-4 inhibitors, such as sitagliptin, linagliptin, sitagliptin, they're named by what they call it, Januvia or others. New medication called the GLT2 inhibitors, such as Jardiance, Forxiga, etc. These, they do not cause hypoglycemia, or if they cause it very infrequently. And so these are preferable for patients to use during Ramadan rather than the sulfonylurea that I mentioned earlier, or the insulin. Of course, sometimes you have to use insulin. You have no choice. Yeah. But so if you compare sulfonylurea, which is like Donel, etc., the incidence about 14-15% of patients who fast develop hypoglycemia.
13 to 14, okay.
Yeah. Compared to almost 3% or whatever. Remember, me and you say my sugar is low. It's actually not low. We just feel hungry, but it's not low. So those medications that don't produce hypoglycemia, about 3-4% people report that symptoms. But with the other one, sulfonylurea, we're talking about 10 to 15%.
Okay. And what about insulin?
Insulin, again, depending what type. If it is only the one type, which is the long-acting, the newer analogs, it's actually slightly less than sulfonylurea because you can adjust it very well. However, if you have to take short-acting, the incidence can go to 30%.
Excellent. Stunning, Dr. Abdulraof. Now we'll go for a report about the effect of fasting on diabetes and cardiovascular disease. To watch more details about this report, stay with us. Don't go away.
Our pursuit of the question whether routine periodic fasting aids individuals in reducing their risk of coronary artery disease and diabetes. One of the things we've found that's very exciting is that fasting is causing the cells throughout the body to go into a self-protection mode where they optimize their operations. The other thing is that it makes the body look for sources of fuel elsewhere other than from food because it doesn't have any. And we have recently been completing a grant project that was funded by the Intermountain Research and Medical Foundation. We enrolled individuals who are pre-diabetic. We measured things related to diabetes such as blood sugar or glucose, and we also measured weight and cholesterol and other factors. We found that individuals who fasted once per week for this month and a half, that they had a reduced weight and also reduced blood cholesterol levels. We now have enough data. We're preparing a grant application for the National Institutes of Health. But initially, the idea that fasting might reduce your risk of coronary disease was, in many people's minds, laughable. The foundation has provided the initial seed money for the studies that we've done on fasting over the last decade. And without the funding support of the foundation, these studies would not have been possible. We're very grateful for all the support that the foundation has provided and for the funds that have been donated by all the donors who support the foundation. It has provided a new piece of information that in the future could be something that will help prevent coronary disease and diabetes and make it so that the problems that are associated with those diseases just don't happen in many lives.
Once again, welcome back to Elixir of Life. Just to remind you again, our topic of this episode is effect of fasting on diabetes mellitus during Ramadan, and our distinguished guest, Dr. Abdulraof AlMahfouz, consultant endocrinologist and diabetologist. Welcome, Dr. Abdulraof. Just to continue our discussion, I think we pose on very important topic and the incidence of hypoglycemia in diabetic patients during Ramadan. Now, the next question, who should fast and who should not fast during Ramadan, meaning diabetic patient?
So in a study that was done about 13 years ago, something like 80% of type 2 diabetes fasted. This study was conducted in 13 countries throughout the Muslim world, all the way from Algeria to Indonesia, while about 50% of type 1 fasted. So most people will be able to fast. However, there are some people who are at much higher risk that should not fast. And we do recommend that they don't fast, although they continue to fast, and it is our duty to tell them what to do. So I think it's much easier to say who should not fast first. People who are at high risk of hypoglycemia, of low blood sugar, these are the ones that we talked about. They do not recognize the symptoms of hypoglycemia. These are the patients who have hypoglycemia, low blood sugar, before, in the last 3 months, severe enough that they have to be admitted because they had coma. Or they have recurrent hypoglycemia, recurrent blood sugar, and they don't know it. These really should stay away from fasting. They are at a very high risk of fast, because we're talking about 15 hours fast. Patients who have other illnesses, such as patients with kidney failure and dialysis, these are very tough patients to even control without fasting, let alone with fasting. So we usually do not advise those people to fast. People who are frail, elderly in their own, who are on medication that produce hypoglycemia. In general, you don't want them to be hypoglycemic because they could fall, they could break their head, they could develop anything. Patients who are type 1, who are pregnant, for example, or tightly controlled, they should not fast, because even with not fasting, they develop low blood sugar on a daily basis. Imagine if they are, if they are fasting. So people who have other illnesses are really, affecting their life, and they need to be looked after well, these should not fast. We come to the people who fast, people who are at the very initial stage of diabetes. They're younger, they're 50. They don't have other health problems. They're on very few medication, or they're on diet alone. These can safely fast without any problem. And there are some people in between. They're healthy, but they're on medication that makes them, or they predispose them to hypoglycemia. The other thing that we look at it, what sort of medication you are taking, regardless of what age you are or what other illnesses you have. So people who are on medications that will not produce hypoglycemia, they should be able to fast, no problem. People who are on medication that can produce low blood sugar hypoglycemia, such as insulin sulfonylurea, they need to take precautions. And so we usually advise them either against if they have problems with other health problems, or either do not fast or adjust their medication in order to reduce this risk so that they don't get into trouble during Ramadan.
Okay, I think that's very important. So we see it's not one size that fits all.
Absolutely.
So they are heterogeneous or group, diabetic patients. Some they can fast, some they don't fast. But from your experience here, we are religious people. We do fast sometimes in spite against the recommendation of the physicians.
That's right.
What are the precautions that should be taken by diabetic patient during Ramadan and before the month of Ramadan?
Yeah. Ideally, we'd like to see the patients a couple of months before Ramadan, so they can prepare whether they can adjust their medication, whether they can change their medication, so that by the time they start fasting, they already know what to do. However, if this is not possible, then depending on what type of medication they take, we can give them the following advice. So if they're taking medications that do not predispose them to low blood sugar, they don't need to do anything in terms of adjustment. However, if they take the medication 3 times a day, they should be able to take it only twice a day. If they take it once a day, they take it once a day with breakfast usually, whether it is sulfonylurea or the others. If they take insulin or sulfonylurea, which is Downhill, Amaryl, etc., then they may need to adjust their medication, specifically the second meal, which is sahur. So generally what we say, what you take in a breakfast during non-fast, you take it iftar which is breakfast, you don't fast. What you take in dinner, you take it with sahur. However, you may need to adjust it by a third or a half, depending on what medication you take. So let's take an example. Let's say a patient is on, let's say, a dimicron, sulfonylurea, once a day. And those patients, and that patient happen to have a reasonable blood sugar. Then it's probably okay to take the same dose. However, if they are predisposed to hypoglycemia before, they need to adjust it downwards by a quarter, probably. Similarly, if they are on insulin one dose, long-acting, with the new insulin analogs such as Lantus or Detamir or Degludec, the newer one, Tresiba, then they may need to adjust it just a little bit, maybe 10%, especially if they don't have low blood sugar. However, if they're using what we call prandial insulin, short-acting for the meal, then the breakfast time they do not need to adjust. What they need to do probably is they need to eat more or less immediately because their sugar is probably in the lower limit. They don't need to wait that long. They just eat immediately. When it comes to sahur, they need to adjust it down probably by a third or a half. That's in general. For the patient who is poorly controlled, where their sugar is always around 200, 250, those patients should not really adjust their medication down, especially if they tell you that I don't have hypoglycemia for the last year.
Okay, means
you know their sugar has been running around 200, 300, and by eating more in Ramadan, their sugar will be higher. And so you don't want them to be even higher by reducing their medication. You want to maintain it the same. That is in a nutshell what should be done. What I always advise people to do is, when they ask me, what should I do in Ramadan? I say, what did you do last year? Because experience of that patient is very important. So if they say, listen, I fasted without an adjusted medication and I did fine, I say continue. If they say no, I used the medication, I developed low blood sugar the first few days, I cut it down and I did okay. So I say, this year, then you need to cut it down. So patient experience in the previous years is very important. And I usually say, follow what you've done, as long as it wasn't the wrong, they call it the wrong adjustment.
Very beautiful, Dr. Abdulraof. What about monitoring of blood sugar during Ramadan, the frequency? Okay.
So in general, patients who are on tablets, who do not produce low blood sugar, they don't need to do much of testing at all. Even if non-fasting, they don't need, as long as they're following a good diet. Patients who are on medication that does predispose them to low blood sugar, they need to test more. Of course, they're not going to test before breakfast, they're going to test before sahur, but the first few days of Ramadan, they really need to test more. And I would recommend maybe 10, 11 o'clock in the morning, maybe 1 o'clock at noon, the first few days, until they know where they're going. Once they know they're fine, they can reduce that frequency to less. If they find that they have to break their fast, then they have to continue monitoring frequently, maybe 2 to 3 times during the fasting period, until they know that their blood sugar is not too low and not too high.
Very beautiful. And again, can we elaborate more on the medication adjustment or adjustment of diabetic medication during Ramadan, particularly insulin? Okay.
So type 1 is the one that are problematic, even type 2. And again, the way I do it is the following. If the patient has very good tight glycemic control, where the blood sugar is close to normal, and they are on insulin, they need to adjust it down. There is no way out of it. They need to cut the insulin dose down. And if they taken a long-acting one dose, then they need probably to cut down that by about 10%, 10, 15.
Like glargine or?
Like glargine, for example, Detamir. People probably know it by Lantus or Levemir or Tresiba. It is the other ones that are problematic, which is the short-acting or intermediate. Intermediate, most people say the cloudy one. The cloudy one can produce hypoglycemia, especially if they take it at sahur time. And that may need to be adjusted by 20% or some people even 30.
So you call it mixed-tarred insulin? This is the one, mixed-tarred insulin?
Mixed-tarred, or even some people are still on the cloudy and the clear, and they mix it because it gives them more flexibility. So if they are tightly controlled, they need to cut the cloudy part by about 25, something like that %. Now, the problem that can happen is the cloudy part doesn't last all the way to the next breakfast. So they may find their blood sugar coming up later on during the day. And if it comes up a lot, then they have to go back a little bit and increase the dose. With the newer analogs, the adjustment is very little. You don't need to adjust a lot. But if you're tightly controlled and the sahur, amount is not as much, you probably need to cut down the short or fast acting by about a third. So if you take 10, you take 7 units, for example, something like that.
But what about the new diabetes medications? We call it incretin mimetic, the Victoza or is it true that this is more, suitable for fasting, Ramadan, less hypoglycemia, or?
Yeah. So there is one full study that was done on that, and the patient who used, we call those GLP-1 agonists, and there are 3 or 4 of them. The one that's available in the market now is Victoza, and I think Bydureon as well. The patients actually do very well, with less hypoglycemia as compared to using sulfonylurea, and they don't eat as much because it also suppresses your appetite. Of course, you're not going to start that during Ramadan. You're going to start it 3 months before Ramadan. So it's already late now to start it in Ramadan. We generally do not recommend starting a new medication in Ramadan of any type because you don't know what you're going to. But people who are on Victoza, for example, do very well in Ramadan. Their control is better, their hypoglycemia is less, and they actually lose weight.
Excellent.
Yeah.
Okay.
So people who can tolerate the medication and they are on it to continue on it, they do very well.
This is very interesting, discussion. Before we conclude with the take-home message, I will ask you about a question that always, circulating in the public. So the definitive treatment of diabetes mellitus is the stem cell transplant.
Yeah.
Is it a myth or fact?
Fact.
Okay.
No, it is not a myth and it's not a fact. It's in between. So what do we have in diabetes? The major defect is the fact we don't have enough cells left to produce insulin. So ideally, you want to replete that cells. And the way to replete it is to get your cells to multiply in the lab and give it back to you. Or use stem cells. Currently, there are no long-term major studies to show the effectiveness of this. So, of course, if you use your own cell, then you should do well, because then you don't need any medication like immunosuppression to prevent rejection. However, now people do have pancreas transplant, let's say transplant, but those require very immunosuppression, which are produce more harm, I believe, than good, and they are only restricted to certain patients who are suffering from hypoglycemia now. So the future, absolutely, the future is stem cell transplant. This is the future where you're going to have enough production of beta cells that produce insulin in the lab that belong to you, and then put it back in the body. We are a good 5 years to 10 years from that, but we are in the way. People may have heard the breakthrough in converting stem cell into insulin-producing cell. These are that have been done about 2 years ago, but it hasn't yet reached a sort of an industrial size way. And the other thing that it hasn't reached, especially in type 1, is the fact that there is no way to prevent the body from destroying it. And that's the next major obstacle that has to be overcome. So there are 2 obstacles, but there is a major breakthrough and a major development that hopefully within 5 to 10 years we'll see. In fact, technology has advanced so much, especially in type 1, we're talking in type 1, that we now have artificial pancreas.
Artificial pancreas.
That's right. So a pump, sensor will tell what they call it, the pump, listen, the blood sugar is low, please stop the insulin. It will stop the insulin. Blood sugar is a bit high, give more insulin. This is a reality. It is available now. Only, I think, in the US, it's only been like around a few months. So technology has progressed so much that people who are pregnant, type 1, people are, kids, this technology will revolutionize their life and make life much more tolerable and make their blood sugar.
It's promising,
That's right, yeah. We're not there yet, at least it's not around here.
Sure. So what's the take-home message, from this, wealthy, discussion, or I would say heavy meal of discussion?
Yeah. So I believe the most important thing is moderation. Moderation in your food, moderation in your exercise, do the right thing, listen to the to the advice, read about it, educate yourself. These are important things. So do not overdo your breakfast. Adjust your medication if necessary. Test frequently when you are on medication that produce hypoglycemia. And God willing, the month will pass by peacefully, and I'm pretty sure the blood sugar will be better.
Thank you, Dr. Abdulraof. I really appreciate you for enlightening us about very important topic, effect of fasting on diabetes control during Ramadan. It was a really great pleasure and honor being with us. It was a fruitful discussion. Thank you, Dr. Abdulraof. Okay.
My pleasure, and blessed Ramadan to you all.
Wish to see you again on our program. Okay.
Thank you.
Dear viewers, now we are coming to the last report for our episode, Health Benefit. To watch more details about this report, stay with us.
Dates are considered a blessed fruit and are especially consumed during the holy month of Ramadan. It is not only a custom to have dates during this holy month, but also a delightful and delicious fruit to eat. It is recommended to start iftar by eating an odd number of dates according to the Prophet, peace be upon him's tradition. Dates provide the body with sugar, helping restore low blood sugar after fasting all day. One of the most common reasons for headaches and dizziness during Ramadan is low blood sugar, which is why eating dates is very beneficial at the start of iftar. But what are the benefits? Well, they provide vitality, being rich in calories and sugar. 80% of a date is made of sugar, as well as being easily digested and absorbed. They provide you with an immediate source of energy. They are rich in essential nutrients. Dates contain 6 vitamins and 15 minerals, and are especially rich in calcium, phosphorus, iron, magnesium, and potassium. They're full of fiber. This helps digestion and moderates bowel function, helping prevent constipation. They only have mild traces of fat, are cholesterol-free, and can be consumed by all members of the family, young and old. 2 or 3 pieces of dates are considered as one fruit serving and have about 70 calories.
Once again, welcome back to our program Elixir of Life. Now we are coming to the end of our show. Before I conclude, I wish you found our episode informative and useful and enjoyable, and would like to thank our great team, starting by cameraman Naif Al-Ataybi, lighting Fahad Lihayan, sound Mohammed Al-Qasim, prepared by Rehab Khleitit, directed by Saghir Al-Shahri, and presented by me, Dr. Mohammed Alsheef. Until next week, we wish you a pleasant week ahead. Ramadan Kareem. Assalamu alaikum wa rahmatullahi wa barakatuh. Take care about yourself.